Good day, dear great surgeons. Today we're gonna talk about physiology void shots for MRCS. Remember, anatomical dead space is measured by Fowler method. Again, the anatomical dead space of the lung is measured by the Fowler method, and this is a very common record, by the way. The physiological dead space is increased by pulmonary embolism, and alveolar ventilation is defined as the volume of fresh air entering the alveoli per minute, and the anatomical dead space is increased by noradrenaline. The type 2 pneumocytes in the alveoli secrete surfactant. The type 2 alveoli secrete surfactant. Glucagon is a protein containing single polypeptide chain produced by alpha cell of pancreatic islets of Langerhans in response to hypoglycemia and amino acid. It increases the plasma glucose and ketones. Cortisol in the stress response has anti-inflammatory effect, skeletal muscle protein breakdown, stimulation of lipolysis, and mineralocorticoid effect. As an anti-insulin effect occur leads to hyperglycemia, not hypoglycemia. So cortisol causes hyperglycemia, not hypoglycemia. Sum up the hormonal response in stress response. The hormones that increase as a stress response, the growth hormone, cortisol, renin, adrenocorticotropic hormone, aldosterone, prolactin, antidiuretic hormone, and the glucagon. They are a lot. So, what decrease? 3. Insulin, testosterone, and estrogen. In the stress, you don't have the estrogen, don't have need for testosterone, and either insulin. And the thyroid stimulating hormone doesn't change with the luteinizing and follicular stimulating hormone in stress. So what stress cause to the hormonal action? Increases the level of the growth hormone, cortisol, renin, ACTH, and aldosterone, prolactin, antidiuretic hormone, and glucagon. But insulin, testosterone, and estrogen are decreased. Insulin, testosterone, and estrogen are decreased. No one will need testosterone and estrogen in the stress, right? In hemophilia A, the BTT is prolonged and there is reduced level of factor VIII. The bleeding time and PET are normal. Cholestatic jaundice prevents the absorption of the fat-soluble vitamin K. Massive transfusion more than 10 blood international unit or equivalent to the blood volume of a person puts the patient at risk of thrombocytopenia, factor V and factor VIII deficiency. Remember, the interpretation of the blood clotting test results in the following diseases. In hemophilia and von Willebrand disease and vitamin K deficiency, the BTT will increase in the 3 diseases, hemophilia, von Willebrand, and vitamin K deficiency. But in vitamin K deficiency, not only the BTT, but the PT as well. In von Willebrand, the BTT and the bleeding time will increase. But in hemophilia, only the BTT will increase. A key in your exam is the hypertension or hypotension. When you see a polytrauma patient with hypertension, you exclude the intra-abdominal bleeding and begin to think in intracranial injury because it will cause raised intracranial pressure. In a polytrauma patient, there is either hypertension or hypotension. That's why the vitals is important in the polytrauma patient. So, if you see hypertension in a polytrauma patient, you suspect intracranial pressure system injury and increase. The compression of the respiratory center will typically result in kinestoke style respiration as well. The Cushing triad will cause a widening in the pulse pressure, respiratory changes, and bradycardia. In Cushing triad, widening of pulse pressure, respiratory changes, and bradycardia. Due to raised intracranial pressure system, hypertension is usually seen, and compression to the respiratory center will typically cause kinestoke style respiration. The electrolytes in our body is very important and crucial in the exam, and the minerals as well. So, regarding hypercalcemia, a many monarchs like chimpanzees can compromise the all causes for hypercalcemia. Calcium supplementation and hyperparathyroidism in the iatrogenic like thiazides and milk alkali syndrome baggage disease of the bone, acromegaly, Addison, and neoplasia, Zollinger-Ellison syndrome, excessive vitamin D and excessive vitamin A, and sarcoidosis. All of those are very known causes for hypercalcemia. But take care. Regarding hyperparathyroidism, only the primary and the tertiary one cause hypercalcemia, while the secondary one causes hypocalcemia. And remember that the celiac disease tends to develop hypocalcemia due to malabsorption of calcium by the bowel. Hyperparathyroidism, the calcium is your key. In the primary and the tertiary, you will find them hypercalcemia. And then you have to look at the renal function, while the secondary one, or the secondary hyperparathyroidism, the calcium will be your key. You will find it hypocalcemia instead of hyperparathyroid hormone. Let's have some notes about the gastric hormone. Most of them, from the initial letter of their letter, denotes their origin cell. The gastrin hormone, for example, from the G cell of the antrum of the stomach, and the secretin from the S cell in the upper small intestine, and somatostatin as an exception with the cholecystokinin from the I cell in the upper small intestine, while the somatostatin from the D cell in the pancreas of the stomach. So again, the gastrin from the G cell of the antrum of the stomach, and cholecystokinin from the I cell in the upper small intestine, the secretin from the S cell in the upper small intestine, while the somatostatin from the D cell in the pancreas and the stomach. The phases of gastric secretion. We have three phases: cephalic phase, gastric phase, intestinal phase. The cephalic phase, when you smell or taste the food itself, and it compromises 30% of the acid production due to vagal cholinergic stimulation, causing secretion of HCl and gastric release from the G cell, while the gastric phase is the major contributor in this gastric secretion cycle due to distension of food, distension of stomach by the food. 60% acid production in the gastric phase itself. So the major contribution by the gastric phase when you eat the food itself, not when you see it with the cephalic phase. And lastly, the intestinal phase, when the food reaches the duodenum, 10% of acid production only. Hyperventilation will induce a state of alkalosis, which will lower the ionized plasma calcium level. Remember, calcitonin secreted by the C cell of the thyroid inhibits intestinal calcium absorption and inhibits osteoclasts activity and inhibits renal tubular absorption of the calcium. So calcitonin is not calcium promoter, but it's calcium inhibitor. Inhibits the intestinal calcium absorption and the osteoclast activity and the absorption of the calcium from the renal tubules. Regulation of gastric acid production. What are the factors that increase the production of gastric acid? The vagal nerve stimulation, gastrin release, and histamine release. So the vagal nerve stimulation and gastrin and histamine, those increase the production of the gastric acid. But what are the factors that decrease the production? Somatostatin, cholecystokinin, and secretin. So somatostatin is antihistamine. Aldosterone is secreted by zona glomerulosa of the adrenal cortex. It's a mineralocorticoid hormone. Secretion is regulated by the renin-angiotensin system and by plasma level of sodium and potassium. Aldosterone converts the sodium by stimulating the reabsorption of sodium in distal nephron in exchange for potassium. That's why the lack of aldosterone will result in hyperkalemia and hyponatremia. High potassium and low sodium. Hyperkalemia and hyponatremia if result from lack of aldosterone. Secretin hormone causes secretion of water and electrolyte. Cholecystokinin causes enzyme secretion. While secretin is typically increasing the electrolyte and water volume of secretion, the enzyme content is increased by cholecystokinin. Somatostatin will decrease the volume of secretion. Aldosterone will tend to conserve the electrolytes. Again, aldosterone will tend to conserve the electrolyte, and its deficiency causes hyperkalemia and hyponatremia. Remember, jaundice will impair the production of vitamin K-dependent clotting factor, and this is most accurately tested by measuring of prothrombin time. The BTT can be affected by vitamin K deficiency due to factor IX deficiency. However, this occurs to a lesser extent, and this is normally associated with the severe liver disease. The bleeding time is a measure of the platelet function. So PT and the prothrombin time, vitamin K dependent factor will be affected, 2, 7, 9, and 10, while the BTT 8, 9, 11, and 12. The adrenal gland releases adrenaline in response to increased sympathetic discharge from the preganglionic sympathetic fiber of splanchnic nerve. These cause the chromaffin cell of the medulla to release adrenaline, which is performed by exocytosis. Adrenaline is a fight or flight response. It's a catecholamine, neurotransmitter and hormone released by adrenal gland, has effect on alpha 1 and 2, beta 1 and 2 receptor. The effect on beta 2 receptor in skeletal muscle vessels, causing vasodilatation, increased cardiac output and total peripheral resistance, vasoconstriction in skin and kidney, causing narrow pulse pressure, while its action on the alpha adrenergic receptor causing inhibition of insulin secretion by the pancreas, and stimulates glycogenolysis in the liver and the muscle. So stimulates as well glycolysis in the muscle, while its action on the beta adrenergic receptor stimulates glucagon secretion in the pancreas and stimulates ACTH and stimulates lipolysis by adipose tissue. Please take care. Adrenaline effect. On alpha adrenergic receptor, it inhibits insulin secretion by the pancreas, while on the beta adrenergic receptor, it stimulates the glucagon secretion in the pancreas. So it inhibits insulin and stimulates glucagon by the pancreas. Take care. The direct effect of the adrenaline on the alpha adrenergic receptor is stimulating the glycogenolysis in the liver and the muscle, and stimulating the glycolysis in the muscle. This is the direct action. The acute phase response include acute phase protein, reduction of transport protein like the albumin and transferrin, hepatic sequestration quotient, and pyrexia, neutrophil leukocytosis, increased muscle proteolysis, and a change in vascular permeability. Patient can be generally managed without transfusion as long as the hemoglobin is 7 or greater. The exact level depends upon patient factors such as comorbidities. All the blood function less effectively and shouldn't be used during massive transfusions. Ventilation control. Control of ventilation is coordinated by respiratory center, chemoreceptors, lung receptors, and muscles. Autonomic involuntary control of respiration occurs from the medulla, and the respiratory center control the respiratory rate and the depth of respiration. Lung receptors include stretch receptors, irritant receptors, and juxtacapillary receptors. The stretch receptors respond to lung stretching, causing a reduced respiratory rate, while the irritant receptor responds to the smoke, causing bronchospasm. Juxtacapillary receptors are the third lung receptor. Take care. Gastrectomy and macrocytic anemia make you think about B12 deficiency. Only 10% of calcium is absorbed from the colon, so that subtotal colectomy won't affect calcium. Lung compliance is a measure of the ease of expansion of the lung and thorax, determined by pulmonary volume and elasticity. A high degree of compliance indicates a loss of elastic recoil of the lungs, as in old age or emphysema. This increased lung compliance is due to loss of supportive tissue around the airways. While a normal lung has a high passive elastic recoil, the sick lung has a decreased elasticity. so decreased transpulmonary pressure, which leads to increased lung compliance, while decreased compliance means that a greater change in pressure is needed for a given change in volume, as in atelectasis, pulmonary fibrosis, pneumonia, or lack of surfactant. Tidal volume is the volume of air inspired and expired during each ventilatory cycle at rest. It is a volume you respire in your normal breathing at rest. It's normally 500 in male and 340 in female. Residual volume is the volume of air remaining in lung after a maximal expiration. Total capacity is the maximal volume of air that can be forcibly exhaled after maximal inspiration. It's around 4,500 in male and 3,500 in female. No worries if you don't know about ECG thoroughly. Take it piecemeal and learn one by one about the waves and one by one about how to read. Don't take it a long shot at once. Every MRCS exam, an inappropriate antidiuretic hormone release, the Sayeda syndrome, is a must in the exam. The drugs causing Sayeda syndrome of inappropriate antidiuretic hormone, analgesics like opioid and nonsteroidals, barbiturates and cyclophosphamide, chlorpromazine and carbamazine, and diuretic. So A, B, C, D causes of Sayeda: analgesics, barbiturates, cyclophosphamide, and diuretics like thiazides. Hyponatremia is a very common question in MRCS as well. Hyponatremia may be caused by water excess or sodium depletion. Causes of pseudo hyponatremia include hyperlipidemia, increase in serum volume, or taking blood from a drip arm, urinary sodium or osmolarity level, aid making a diagnosis. The CSF fills the space between the arachnoid mater and the pia mater, covering the surface of the brain. The total volume of CSF in the brain is approximately 150 milli. Approximately 500 milli is produced by the epididymal cyst in the choroid plexus, 70%, or blood vessels 30%. So 70% by the choroid plexus and 30% by the blood vessels. It's reabsorbed via the arachnoid granulations, which project into the venous sinuses. The circulation of the CSF, it's a must in the exam, and very important and very recurrent recall. It may ask about a step or a block in a step. So, let's start it. Start at the lateral ventricle via foramen of Monroe, then to third ventricle, cerebral duct, and fourth ventricle, then subarachnoid space, reabsorbed into the venous system via arachnoid granulation in the superior sagittal sinuses. So, from the lateral ventricle via the foramen of Monroe, then to the third ventricle and the cerebral aqueduct of Sylvius, then fourth ventricle via the foramina of Magenta and Loschka. Subarachnoid space reabsorbed again in the venous system via arachnoid granulation in the superior sagittal sinus. The CSF composed of glucose, protein, RBC, no RBC in CSF, and white blood cells. So you can see white blood cell, but never RBC in the CSF. Glucose from 50 to 80 mg per deciliter, white protein from 15 to 40 mg per deciliter, but no RBC. You can find white blood cells from 0 to 3 cells per millimeter cube. Remember, myofibroblasts are differentiated fibroblasts in which the cytoskeleton contain actin filament, myoactin, myofibroblast, differentiated fibroblast. These cell types facilitate wound contracture and are the hallmark of the mature wound. That's why they're almost never found in the wounds less than 1 month old. Insulin half-life is less than 30 minutes. Abnormalities in the clearance of insulin may occur in type 2 diabetes. Insulin is a peptide hormone produced by beta cell in the pancreas and is central regulating of carbohydrate fat metabolism in the body. Insulin causes cells in the liver and skeletal muscle and fat tissue to absorb glucose from the blood. Insulin doesn't glucose to be free in the blood. In the liver and skeletal muscle, glucose is stored as glycogen, and in fat cells, adipocyte is stored as triglycerides. Human insulin protein is composed of 51 amino acids and has a molecular weight of 5808 Da, and it's a dimer of an A chain and beta chain, which are linked together by disulfide bond. Composed of 51 amino acids. Insulin is a peptide hormone from beta cell of pancreas. Calcitonin has the opposite effect of parathormone and is released from thyroid glands. Dobutamine or dobutamine is a sympathomimetic with both alpha and beta agonist properties. It displays a considerable selectivity for beta-1 cardiac receptors. So, for both alpha and beta agonist properties, and display considerable selectivity to beta-1 cardiac receptors. The beta receptors are inhibitory receptors except for the heart. The beta receptors are inhibitory receptors except for the heart. Histamine is released from enterochromatin cells in the stomach mucosa, which stimulates acid secretion. It's usually released in response to increased serum gastrin level. Histamine blockers were extremely popular treatment until the advent of proton pump inhibitor. Hypoxemia and acidosis may both affect cerebral blood flow. However, in the traumatic situation, increased intracranial pressure are far more likely to occur, especially when Glasgow Coma scale is low. This will adversely affect cerebral blood flow. Novocaine blocks sodium channel. That's why patients sense some pain during the introduction of the local anesthesia. During acute inflammation, just like appendicitis, neutrophils polymorph are the cell type most commonly encountered in this acute inflammatory process. The slow transmission of mechanothermal stimuli is transmitted via C fiber. Mechanothermal via C fiber. The alpha and gamma fibers transmit information related to motor proprioception. Motor proprioception by the alpha and gamma fibers, while the alpha and the beta fiber transmit touch pressure. Touch and pressure by alpha and beta, while beta alone fiber are autonomic fiber. So C for mechanothermal, alpha and gamma for motor proprioception, while the alpha and beta transmit touch and pressure, and the beta is autonomic fiber. Our body fluid volumes are contained within compartments: the intracellular, extracellular, plasma, interstitial, and transcellular. The intracellular compartment contains about 60 to 65%, which is the largest percent of the total body volume, while the next one is the extracellular with 35 to 40% of the total body volume. The plasma only 5%, while the interstitial about 24%. It is responsible for regulating ion exchange in salivary gland. It acts on sodium-potassium ion exchange pump. It's a mineralocorticoid hormone that derived from the zona glomerulosa of the adrenal gland, remember? And its deficiency will cause... The deficiency of aldosterone will cause hyperkalemia and hyponatremia, increased potassium and low sodium. Hyperkalemia and hyponatremia is caused by deficiency in aldosterone. Addison disease is adrenal insufficiency. According to the MRCS, TB is the most common cause for Addison disease. worldwide, but it's rare in UK. Take care. The effect of release of vasopressin from the pituitary gland is that it increases water permeability of the distal tubule of the kidney. The ADH, which is the vasopressin, results in the insertion of aquaporin channel in apical membrane of the distal tubule and collecting tubules. The maximum voluntary ventilation is the maximal ventilation over the course of 1 minute. Maximal inspiration. Maximum volume of air that can be forcibly exhaled after the maximal inspiration. Vital capacity. This is the vital capacity is the maximum volume of air that can be forcibly exhaled after a maximal inspiration. Care from the respiratory function, terminologies, and definitions, especially the residual volume and the functional residual capacity. The volume of air remaining in the lung after a maximal expiration, this is the residual volume, while at the end of the normal expiration, the volume remaining in the lung is the functional residual capacity. Volume remaining in the lung at the end of a normal expiration is the FRC, the functional residual capacity. The volume of air remaining in the lung after a maximal expiration is the residual volume. The loss of vitamin A will result in impaired rhodopsin synthesis, and this will result in poor night vision. Plasma typically accounts for 4 to 6% of the body weight in healthy individuals. Males typically have more water per unit weight than females, as females have a higher fat content. The 60-40-20 rule. 60 total body weight is water. 40% of total body weight is intracellular fluid, while 20% of the body weight is extracellular fluid. And again, plasma typically account for 4 to 6%. Patient can generally be managed without transfusion as long as the hemoglobin is 7 or greater. The exact level depends upon the patient factors such as comorbidities. All the blood transfusion less effectively and should not be used during massive transfusion. Note that the stored blood become more acidic. Remember, fresh frozen plasma is not the first line for hypovolemia. The cryoprecipitated is rich source of factor VIII and fibrinogen, and allow large concentration of factor VIII to be administered in a small volume. A very nice idea intraoperative is the cell saver device. These collect patient-own blood lost during surgery and then reinfuse them. There are two main types: those which wash the blood cells prior to reinfusion, and those which don't wash the blood prior to reinfusion. Let's have a glimpse about those which are used to wash the blood prior to reinfusion. These are more expensive to purchase and more complicated to operate. However, they reduce the risk of reinfusion contaminated blood back into the patient. The main advantage is that they avoid the use of infusion blood from donor into patient, and this may reduce risk of blood-borne infection. It may be acceptable to Jehovah's Witness. It's contraindicated in malignant disease for risk of facilitating disease dissemination. Have an immediate or urgent surgery in a patient taking warfarin. 1. Stop warfarin. 2. Start vitamin K. The reversal will be within 4 to 24 hours. IV takes about 4 to 6 hours to work. At least 5 mg or oral vitamin K can take 24 hours to be clinically effective. 3. Fresh frozen plasma. Fresh frozen plasma in the patient taking warfarin used less commonly now, as the first line of warfarin reversal is 30 ml per kg. Need to give at least 1 liter fluid in 7 kg patient, therefore not appropriate in fluid overload. Need blood group, and only use if human prothrombin complex is not available. The human prothrombin complex reversal within 1 hour. The periplex 50 microgram. Rapid action, but factor 6 short half-life, therefore given with vitamin K. So again, if you have an immediate or urgent surgery in patient taking warfarin, stop warfarin, start vitamin K, either IV or oral, which IV will be faster, and start human prothrombin complex. And always remember that the fresh frozen plasma is not the first line anymore, because you need to give at least 1 liter fluid in a 70 kilogram person, therefore not appropriate in fluid overload, and need blood grouping. Only use if human prothrombin complex is not available. The adrenal gland releases adrenaline in response to increased sympathetic discharge from the pregangliotic sympathetic fibers of the splanchnic nerve. These cause the chromaffin cell of the medulla to release adrenaline, which is performed by exocytosis. Lung compliance is defined as the change in lung volume per unit change in air pressure. Causes of increased lung compliance, the age, and emphysema. This is due to loss of alveolar wall and associated elastic tissue. And from the causes of decreased lung compliance, the pulmonary edema, pulmonary fibrosis, pneumonectomy, and kyphosis. Hypothalamus is the thermoregulator of the body. It may rely on the cerebral cortex to induce behavioral adaptation to facilitate the thermoregulatory process. Remember, the first response from the body towards hypothermia is vasoconstriction, then shivering. Vasoconstriction, then shivering. Take it a rule. The nervous response before the motor response. The nervous response before the hormonal response. The nervous response is faster than the hormonal response, but shorter. The hormonal may be delayed, but it will be longer. So, in hypothermia, for example, the hypothalamus will initiate involuntary motor response to raise body temperature like shivering, but it will start with the sympathetic nervous system to produce peripheral vasoconstriction before shivering. And this due to the release of adrenaline from the adrenal medulla. The spleen has several rules in our body, like iron reutilization, storage of platelets, storage of monocytes, even hematopoiesis in hematological disorder. But the reservoir function of the spleen is less marked in humans than other animals, and a normal individual can sequester between 5 to 10% of the red cell mass. The other stated processes like the iron neutralization and storage of platelets, storage of monocytes, hematopoietic action are the main function and account for the function of the spleen. So again, the function of the spleen: filtration of abnormal blood cell and foreign bodies such as bacteria, immunity IgM production for probertin and toxin, which help target fungi and bacteria for phagocytosis, hematopoiesis up to 5th month gestation or hematological disorder, pooling of the blood, which is storing of 40% of the platelet, not reservoir, pooling for storage of 40% of the platelet, and iron utilization and the storage of monocytes. Remember, insulin and thyroxine are often have a reduced level in secretion in post-operative period, just like any other stress periods. And this coupled with increased glucocorticoid release which may cause a difficulty in management of diabetes in individuals with insulin resistance. That's why stress can cause hyperglycemia, not a hypoglycemia. So, let's remember again the hormonal change in stress response. The hormones that increase, like growth hormone, cortisol, renin, adrenocorticoids, and aldosterone, prolactin, antidiuretic hormone, and glucagon. But the hormones that are decreased in stress, like insulin, testosterone, and estrogen. There is no change in thyroid, luteinizing hormone, and follicle-stimulating hormone. Remember, the thyrotropin-releasing hormone stimulates the prolactin. The TRH, thyrotropin-releasing hormone, stimulates the prolactin release, while the dopamine suppresses the release of prolactin. Prolactin release stimulates the milk productivity, but it reduces the gonadal activity. Renin is secreted by the juxtaglomerular cells and hydrolyze angiotensinogen to produce angiotensin 1 from the factor stimulating renin secretion, hypotension, hyponatremia, sympathetic nerve stimulation, catecholamines, and erect posture. And from the factors that reduce the renin secretion are drugs like beta-blocker and non-steroidal anti-inflammatory drugs. Again, the factors stimulating renin secretion, hypotension, hyponatremia, sympathetic nerve stimulation, catecholamines, erect posture. While the factors that reduce the renin secretion are drugs like beta-blocker and non-steroidal anti-inflammatory drugs. We have 4 types of opioid receptors: the gamma, kappa, mu, and nociceptin. The gamma count for the analgesic and antidepressant, while the kappa is for analgesic and dissociative effect. The mu, and please remember the mu receptor, which causes analgesia, meiosis, and decrease the gut motility. This is a very common be asked after the exam and in the exam and within the exam study. It's a very common record including the mu receptor causing analgesia, meiosis, and decreased gut motility. The nociceptin receptor affects the appetite and tolerance to mu agonists. Triad of Wernicke's encephalopathy is acute confusion, ataxia, and ophthalmoplegia. The oxygen hemoglobin dissociation curve is a very crucial exam topic. So let's start by left and right and lower and raised. When it shifts to the left, it will lower oxygen delivery. Shift to the left will lower oxygen delivery, while shifting to the right will raise oxygen delivery. So when you are talking about shifting to the left of the curve, which means lowering oxygen delivery, think about the causes that will cause lowering oxygen delivery, like methemoglobin and carboxyhemoglobin, low PCO2 or low DBG or low temperature. While shifting to the right, raising the oxygen delivery means raise the protein, which is more acidic, and raised BCO2 and raised DBG and raised temperature. So low left, low temperature and alkali, while right, raise oxygen and raise temperature and acid. The oxygen dissociation curve is a curve that is used to describe the relation between the percentage of saturated hemoglobin and partial pressure of oxygen in the blood. It's a curve to describe the relationship between the percentage of a saturated hemoglobin and partial pressure of oxygen in the blood. It's not affected by the hemoglobin concentration. Take care. The oxygen dissociation curve is not affected by the hemoglobin concentration. The chronic anemia causes 2-3 DBG level to increase, and hence shifting the curve to the right. A famous question of ECG that the atrial repolarization is generally not visible and masked by the QRS complex and not visible in the ECG strip. Take care. The atrial repolarization is not represented on the ECG strip because it occurs during the QRS complex. Okay, what is the QRS? We know that ECG starts by the letters PQRS, and those were the middles of the alphabet because who invented the ECG decided to choose the middle of the alphabet because if anyone discovered new waves should be before P and after the S. Yes, and they when discovered the T and the W, they added the T and the W. So now we are talking about PQRS simply. That's why they choose to name them PQRS. So take care. B wave is the atrial depolarization, not repolarization. The atrial depolarization is represented on the ECG strip by the P waves, while the atrial repolarization is not represented because it's hidden and masked by the QRS complex. The QRS complex represents the ventricular depolarization. So the atrial depolarization represented by the B wave, while the QRS complex represents the ventricular depolarization. The ventricular repolarization is represented by the T wave. And this is very important wave in fact, because inverted T wave may indicate ischemia or MI. We won't go deep, just know that T wave represents the ventricular repolarization, while the QRS complex represents the ventricular depolarization, the repolarization by the T wave of the ventricles. And the T wave is very important to indicate ischemia. We will talk it later, but take this piecemeal, step by step. You can conquer the ECG, and ECG is a must in the exam. You will take at least 5 questions in ECG, and you can take them all. Acute phase protein, CRP, procalcitonin, ferritin, fibrinogen, alpha-1 antitrypsin, ceruloplasmin, serum amyloid A, haptoglobin, and complement. Those are the acute phase protein. During the active phase, the acute phase response, the liver decreases the production of other proteins, like the albumin and the transthyretin and the transferrin and retinol binding protein, cortisol binding protein. The conflict here is between the ferritin and the transferrin. The ferritin and the transferrin. The transferrin is decreased by the liver in the acute phase response, while the acute phase protein increases the ferritin. Acute phase protein, ferritin. The liver will decrease the transferrin. It's a musical, right? The acute phase protein, ferritin. The liver will decrease the transferrin. Acute phase protein, ferritin. The liver will decrease the transferrin. In acute tubular necrosis, there is no response to intravenous fluids because the damage occurs from within the renal system, not as a result of volume depletion. It's because of the damage occurred within the renal system, not the volume depletion. Peristalsis, we have two muscles, the circular and the longitudinal. The circular smooth muscle contracts behind the food, while the longitudinal smooth muscle propels the food through the esophagus. Primary peristalsis is spontaneously moves the food from the esophagus to the stomach. It will take about 9 seconds. The secondary peristalsis occurs when food which doesn't enter the stomach stimulate a stretch receptor to cause peristalsis. In the small intestine, each peristalsis wave slows to a few seconds and causes mixture of chyme. In the colon, three main types of peristalsis activity are recognized. What are those three types? The colonic peristalsis are three: segmentation, antiperistaltic, and mass movement. The segmentation contraction. They are localized contraction in which the bolus is subjected to local forces to maximize mucosal absorption. So segmental contraction to maximize mucosal absorption. While the antiperistaltic contraction toward the ileum, localized reverse peristaltic wave to slow entry into colon and maximize absorption. While the mass movement waves migratory peristalsis wave along the entire colon to empty the organ prior to the next ingestion of food bolus. So, peristalsis occurs starting from the esophagus and the stomach, then small intestine and the colon. Take care. Vitamin K deficiency will result from cholestatic jaundice and prolonged antibiotic therapy. Acquired factor 12 deficiency causes prolonged PTT. Humble proteins, just like the ferritin with a small letter count, you will be increased. But with high number of letters, just like the transferrin, you will be decreased. Consider it as a wisdom. So, in acute phase protein, the ferritin is humble with little letters, so it will increase, while the transferrin is not humble with much letters, and this will be decreased in acute phase protein. This reminds me of the gluteus maximus nerve and blood supply with the superior gluteal nerve and superior gluteal artery, while the medius and minimus of the glutei are supplied by the superior gluteal artery and nerve. A locally perforated colonic tumor will typically cause the intense inflammatory response, and if peritonitis is not present in the case clinically, then at least a localized abscess may occur. The inflammatory process will cause a falsely raised serum ferritin level. Angiodysplasia and the dilaphoid lesion are mucosal arteriovenous malformation and unlikely to result in considerable inflammatory process activity. So a perforated colonic tumor may cause an inflammatory-like response which may falsely raise the serum ferritin. And remember, the ferritin is the humble with little letters which increase in the acute phase protein, while the transferrin with much letter will decrease in the acute phase protein. Ferritin is intracellular protein that binds iron and stores it to be released in controlled fashion at the sites where iron is required. Because iron and ferritin are bound, the total body ferritin levels may be decreased in case of iron deficiency anemia, but it will increase in inflammatory process. So, in case of iron deficiency anemia, you will find the ferritin decrease, but in the inflammatory process, as an acute phase protein, it will increase. And take care, it might be falsely increased, just like the tumor, the colonic tumor. Take care. Preload is the same as end-diastolic volume. When it's increased slightly, there is an associated increase in cardiac output. The Frank-Starling principle. When it's markedly increased, example over 2050 milli, then cardiac output falls. So the preload is the same as the diastolic volume. When it increases slightly, there is an associated increase in the cardiac output. Water absorption in the GIT predominantly occur in small bowel, the jejunum and the ileum. The colon is an important site of water absorption. However, its overall contribution is relatively small. The importance of the colonic component to water absorption may increase following extensive small bowel resection. The bile is produced at a rate between 500 to 1500 per day. Bile is composed of bile salts, bicarbonates, cholesterol, steroids, and water. Again, bile salts, bicarbonate, cholesterol, steroid, and water. There are three main factors regulating the bile flow: hepatic secretion, gallbladder contraction, and sphincter of Oddi resistance. Bile salts are absorbed in the terminal ileum and recycled to the liver. Over 90% of the bile salt are recycled in this way, such that the total pool of bile salt is recycled up to 6 times a day. A patient who is diagnosed with compartment syndrome and delayed the diagnosis will lead to muscle death, which will release potassium and hemoglobin and will eventually lead to renal impairment and maybe multi-organ failure and death. So take care, diagnose early, and the hyperkalemia is due to muscle death. Remember that the beta blockers interfere with potassium transport into the cell and can potentially cause hyperkalemia as well in renal failure patients. Beta blocker can cause hyperkalemia in renal failure patients. Remember, beta agonists like salbutamol are sometimes used in emergency treatment, so take care in renal failure patients. We all use heparin, but did you know that both unfractionated and low molecular weight heparin can cause hyperkalemia? So, take care. Hyperkalemia causes like acute renal failure, drugs like potassium-sparing diuretics and ACE inhibitor and angiotensin II receptor blocker and spironolactone, cyclosporin, even heparin, and the beta blocker in renal failure patients. Metabolic acidosis, Addison disease, and tissue necrosis, rhabdomyolysis, burn, trauma, massive blood transfusion, all of these can cause hyperkalemia. And take care from the foods that contain high level of potassium, just like the salt substitutes which contain potassium rather than sodium. And of course, banana, orange, kiwi, avocado, spinach, and tomato. We all know that banana has a high level of potassium, but take care as well from the orange, kiwi fruit, avocado, and spinach and tomato. Hyponatremia causes can be classified according to the cause, and the result of the lab will aid us to know the cause. Urinary sodium, if more than 20 millimole per liter, will be mostly about sodium depletion renal loss, while if the urinary sodium less than 20 millimole per liter will be sodium depletion extra renal loss. But take care, it may be also due to water excess. Patient will be often hypovolemic and edematous. Hypovolemic and edematous due to water excess. Real features of the substance used to measure the GFR to be inert and free filtered from the plasma and the glomerulus. No protein bounding. Not absorbed or secreted at the tubule. Plasma concentration will be constant during urine collection. Remember that creatinine declines with age due to decline in renal function and muscle mass. Glucose, protein, and PAH, para-amino hyperboric acid, reabsorbed by the kidney and can be used to measure the GFR. The GFR, which is the glomerular filtrate rate, is equal to the concentration of a solute in the urine times the volume of the urine produced per minute, divided by the plasma concentration, assuming that the solute is freely diffused, like the inulin. Patients with malabsorption may develop magnesium deficiency. Although TBN feeds may have contained magnesium, it may not have been sufficient to correct the loss. Sodium phosphate and potassium would have this effect on serum calcium. Magnesium is required by both parathyroid secretion and its action on target tissue. Hypomagnesemia may both cause hypocalcemia and render patient unresponsiveness. to treatment with calcium and vitamin D supplementation. Cortisol is a glucocorticoid released by the zona fasciculata of the adrenal gland. 90% are protein bound while 10 are active. Circadian rhythm high in the morning, negative feedback by ACTH, and the actions are glycogenolysis, it breaks down the glycogen, and gluconeogenesis, creates new glucose, which will cause hyperglycemia and stress. Protein catabolism, lipolysis, stress response, anti-inflammatory, decrease protein in the bone, increase gastric acid, increase the neutrophil, platelet, red blood cells, and inhibit fibroblastic activity. Okay? That's all about cortisol. When the question tells you about the stool of the patient, be alert. The stool sticking to the commode and not flushing, this is steatorrhea. Loss of lipase is one of the key features in the development of the steatorrhea, which is typically consistent of a pale, offensive stool that difficult to flush out. Okay? Graves is a primary thyrotoxicosis, which will be managed mainly medically by carbamazole and beta blocker. In pregnant, you will use propylthiouracil. We only use surgical option in Graves if she didn't, and we use term she because thyroiditis is more common in female 10 to 1 rather than male. More common in female, that's why I said she. So if she didn't respond to the medical treatment for 18 months and there is no remission, we can talk about the options of surgeries then. So compliance again is a change in lung volume per unit change in airway pressure, and decreased by pulmonary edema and fibrosis, pneumonectomy and kyphosis, and it can increase by the age and emphysema. This is due to the loss of alveolar wall and associated elastic tissue. Compliance, think of it like a rubber. When the rubber fibrosed or the rubber in edema or caused cut in this rubber, it will decrease its elasticity, decrease its compliance. Inhibition of insulin release can be caused by alpha-adrenergic drugs and beta blockers, alpha-adrenergic and beta blockers and sympathetic nerve. Spleen has been withdrawn in 2007 because although it reduces the fibrinolysis and thus bleeding, it's associated with increased risk of death. Protein C is dependent upon vitamin K, and this may paradoxically increase the risk of thrombosis during the early phases of warfarin treatment. Adrenal physiology is commonly asked in the exam. The adrenal has medulla and cortex. The cortex is the outer layer, medulla is the core. The medulla chromaffin cell of the adrenal medulla secretes catecholamine, the noradrenaline and the adrenaline from the core, from the medulla. The medulla is innervated by splanchnic nerve and preganglionic sympathetic fiber secreted acetylcholine, causing the chromaffin cell to secrete their content by exocytosis. The phaeochromcytoma is derived from these cells, the chromaffin cell, and will secrete both adrenaline and noradrenaline, again from the medulla in the core. The adrenal cortex histologically have three distinct zones, the glomerulosa, fasciculata, and verticularis. From outer to inner zone, glomerulosa, fasciculata, and verticularis. The glomerulosa, the outer zone, secretes aldosterone, while the fasciculata glucocorticoids and the verticularis androgens. To calculate the anion gap, sodium and potassium are friends, bicarbonate chloride are friends. Add the sodium and potassium and add the bicarbonate and chloride. Subtract the bicarbonate and chloride from the sodium and the potassium. This is the anion gap simply. Hypercapnia will tend to produce cerebral vasodilatation. This is of considerable importance in patients with cranial trauma, as it may increase intracranial pressure. cell which depend on Cori cycle to meet its energy need, it's erythrocyte. This is a very common recall. Erythrocyte doesn't have mitochondria and therefore will generate energy by glycolytic pathway only. All the other cell types have mitochondria and will therefore use the Krebs cycle unless true anaerobic condition prevail. When you are searching for metabolic acidosis, search for pH to be acidic and you have to be losing base. Nothing to do with the carbon dioxide and the oxygen saturation. The tranexamic acid is synthetic derivative of lysine. The primary mode of action is antifibrinolytic that competitively inhibit the conversion of plasminogen to plasmin. So plasmin degrades fibrin and therefore rendering plasmin inactive slows this process. The role of tranexamic acid in trauma was investigated in CRASH 2 trial and has been shown to be benefit in bleeding trauma when administered in the first 3 hours, and this is according to the ATLS protocol 10th edition as well. Subduration of parathyroid gland may result in impairment of blood supply. The serum parathormone level can then fall quickly and feature hypocalcemia, which will cause neuromuscular irritability and laryngeal spasm. Administration of intravenous calcium gluconate can be life-saving in this case. Take care, carotid bodies are the most vascular site and hypercapnia the most potent stimulus. Great surgeons, take care from the baroreceptor and the chemoreceptor are different entities. Baroreceptor are mechanoreceptors that respond to blood pressure changes, while the chemoreceptor are sensory cells that responds to chemical composition changes in the blood. Baroreceptor respond to blood pressure changes, while chemoreceptor respond to the concentration of the chemicals in the surrounding extracellular fluid. The location of the chemoreceptor found in the carotid bodies and the aortic bodies and on the ventral surface of the medulla, while the baroreceptor found in the carotid sinus and the aortic arch. They are near each other, but they are totally different. The reflex of the baroreceptor reflex keep the blood pressure in normal range, while the chemoreceptor reflex keep the level of the oxygen, carbon dioxide, and pH level in the normal range in the blood. Take care. So, the chemoreceptor are located next to the baroreceptor in the carotid body and the aortic body. And the chemoreceptor send signals and signals to the cardiovascular center in the medulla when there is a low oxygen, which is hypoxia, or high carbon dioxide, which is hypercapnia, or high proton, which is acidosis. So, chemoreceptors are active and send signals to the cardiovascular centers in hypoxia, hypercapnia, and acidosis. Chemoreceptor different from the baroreceptor. Again, the physiological dead space of the lung increased by pulmonary embolism, while the anatomical dead space increased by noradrenaline. Take care. Inulin is the most accurate measurement for the GFR. The glomerular filtrate rate is measured by the inulin because creatinine declines with age due to decline in the renal function and muscle mass. The glucose and protein and para-aminohyperic are absorbed by the kidney and can be used as a measurement for the GFR. So the inulin is the most accurate measurement for the GFR. Take care. Lung compliance. It's the easiness of the expansion of the lung. Example, the balloon is compliant. Auto tire is less compliant. The tire requires much greater pressure to expand the compliance. So, the compliance is the balloon theory of the lung. The factor that decreases the compliance, the factor that turns the lung into a tire of the car, is the surface tension of the fluid lining the alveolar surface and the elastic tissue in the alveolar wall, and the expansion of the lung stretches the lung are less compliant. Like in the high ventilation, the ventilation to high lung volume will cause the expansion of the lung and decrease the lung compliance. While the factor that increases the compliance, like the pulmonary surfactant secreted by type 2 alveolar cell, reduces the surface tension of the alveolar fluid, mixture of phospholipid and protein, and low level in premature infant, like the RDS, will increase the lung compliance. Oxygen dissociation curve is very important because the curve is shifted to the right when there is an increased oxygen requirement by the tissue. This includes increased temperature, acidosis, increased DBG, and by the way, the DBG is found in the erythrocyte, is increased during glycolysis and bind to the hemoglobin molecule, thereby release oxygen to the tissue. So if there is no DBG, there is no release to the tissue. DBG is increased in conditions associated with poor oxygen delivery to the tissue, such as anemia and high altitude. Did you know that stored blood has less 2,3 DBG and therefore has higher affinity for oxygen, and this reduces its ability to release during metabolizing the tissue? High affinity to oxygen means it grasps the oxygen and never let it go for the tissue.